method evaluation, and quality control. Here are your objectives. I'll let you read through. All right, so we're going to start with statistical concepts. So statistics is defined as the science of gathering and analyzing, interpreting, and presenting data. So accuracy is without error or closeness, or closest to the true value. So the measured value is closest to the true value, and whereas precision is the closest of repeated results. So think about reproducibility. This can be expressed as standard deviation or coefficient, and typically we use precision, which equals coefficient of variation. When we plot the control values, we will use a Gaussian curve. This should be a bell shape. Statistically, 68.2% of your data points are going to fall within plus or minus 1 standard deviation, where 95.5% will fall within plus or minus 2 standard deviations. And then 99.7% of your points will actually fall within plus or minus 3 standard deviations. The plots can be calculated by summing the values and dividing by the number of values. A median is the value of control results that divide the data into two groups. The mode is defined as the most frequent observation, and if we're talking about Gaussian distribution, then mean, mode, and median are almost always equal. Standard deviation. This is a dispersion or a spread of data around the mean from its estimated range. It's a commonly used statistic for describing dispersion. It is called standard deviation. You'll see that labeled as a capital SD or lowercase. Typically within the clinical laboratory, we use the limit at 95% or plus or minus 1.6 standard deviation. You can see the video down below that will help you understand how to calculate standard deviation.
I've been a social worker long enough that I've seen a lot of.
We can also calculate a coefficient of variation. Remember, this is a measurement of precision, so we need to have already a standard deviation and a mean calculated. So we're going to take the standard deviation and divide it by the mean and then multiply it by 100. The reason we multiply it by 100 is because the coefficient variation will always be expressed as a percentage. And again, this is precision of your methodology. So once again, you can watch the video down below and that will help you understand how to calculate coefficient of variation.
I've been a social worker long enough.
So each analyte that we measure in the laboratory has a reference interval. Sometimes we call it a reference range. Of the older terminology was normal range. So tests are ordered to determine prognosis, confirmation of a previous result, abnormal results, screening, and possibly monitoring of a therapeutic drug level. So the values that we provide to physicians allow to assist in diagnosis of the issue with the patient. So we compare results to a reference interval. The reference intervals are defined as a usual value for a healthy population. Moderate to large size hospitals should determine their own reference ranges as they can vary from the general population. When you determine your own reference ranges, you do need patients of varying ages, and you do need both genders. Typically, for some analytes, there are age categories. They could be very much different depending on the age of the patient. So a newborn level, pre-puberty, and adult, and then all the way up to geriatric adult as well. The recommendation is that you have at least 40 samples are used to establish your range. We talked about predictive values. So sensitivity is the proportion of patients with the disease that actually test positive. So to do this calculation, you're going to take your total positives divided by your total positives plus your total negatives. And then again, we're going to multiply that by 100. So again, sensitivity is the proportion of patients that have the disease that test positive, and specificity is the proportion of patients without the disease that test negative. So the formula for that is total negatives divided by total positives plus the total negatives times 100. So that is how we will report sensitivity and specificity. If you take a look at that little chart I have down in the bottom corner, that will kind of help maybe align this a little better. We also have the equations on there as well. For implementation of a new method, you will need to validate that your manufacturer's reference range or establish your own reference range. You need to have a procedure written and or updated. All personnel need to be trained. You need to implement a statistical quality control program, and if allowable, perform comprehensive comparison of methods. You're going to want to experiment, so you're going to do the methodology comparison between your old and your new test to make sure that it's where you want it to be. So when we talk about quality assurance and quality assurance is the overarching umbrella and quality control is a small component of that. So quality control is a lab system for recognizing and minimizing analytical errors. Again, quality control or QC is just one component, where quality assurance, oftentimes it's referred to as a QA program. Its systematic actions are necessary to provide adequate confidence that the lab will satisfy medical needs for the patient care and resulting in positive patient outcomes. Quality assurance includes all pre-analytical, analytical, and post-analytical factors. So let's talk about those quality assurance factors a bit more. So pre-analytical phase is anything that happens before the specimen is actually, collected. So whether you're doing a manual procedure or an automated procedure, but before that procedure starts, the patient preps. So you have the sample collection, sample handling, storage and transport, those sorts of things are all considered pre-analytical. Analytical phase, that involves your instrumentation, so your reagents, your daily, weekly, monthly preventative maintenance on your analyzers, your function charts, your water quality, your calibrations of your pipettes, stability of your electrical power and temperature checks, reagents and kits, and everything they do in the lab is dated. So when it's received, and it's also dated when it's opened on new lots. Particularly standards and control material will be run parallel with old lots before using for analysis. So again, you need to determine if your new lot is going to cause you a shift in your confidence interval for your controls. Quality control itself is to monitor analytical processes. It helps to detect analytical error during the analysis and to prevent reporting of incorrect patient values. So we're measuring stable control material and then comparing those measured values with the expected value that we are expected to get. There are two types of error. We talk about quality control and we talk about random and systemic error. So random affects your precision. It's a difference between repeated measurements. So maybe variation in technique, variation in the system, and technique variation. On the other hand, is the factor that contributes to a constant error, whether it's a positive or negative. When we talk about the dispersion or standard, could be due to coordinate standards that have been repeatedly used of reagents, that are repeatedly used failure of the instrument that nobody has considered, or laboratory staff that are simply just not following on the procedures. Quality control material, again, should be the same matrix as the specimen. You're going to generally have a minimum of 1 year expiration date or a minimum 1 year supply. We want to make sure it's stable. We're also going to test it in the same manner as patients. So if you put them all on as a run, you're going to do that the same as the quality control. You're not going to treat them any different because we want it to try to be the same as possible. We're also going to use 2 levels generally. It's a normal and an abnormal. Some will have more than 2, so just be aware of that. And then if you have to reconstitute your control material, make sure you're using care in adding water and mixing. Some have that you add water and then you let it sit. Some have you add water and you need to, shake it up or invert it. So just make sure you're following those manufacturer recommendations. For a statistical quality control system, we use this to monitor analytical variations during testing. So we have three-stage process. So you're going to establish your allowable limits for variation. So that's your plus or minus 2 standard deviation. You're going to have to use limits as criteria for evaluating that QC. So we're going to talk about Westgard rules, and then you need to know what type of remedial action or corrective action on them that's indicated. So finding a cause of errors, correcting them, reanalyzing the patient if your quality control is unacceptable. If it is unacceptable, you cannot report patient results until your corrective action is within range. So again, your quality control system typically is going to analyze 2 different levels of control for 10 to 20 days. Typically, if you're adjusting for a new standard deviation, you need at least 20 points of data. You're going to calculate the mean and the standard deviation. You may need to review data as more when it's become available. We're going to apply those control rules to determine if your data is acceptable or needs to be rejected. If the process is in control, again, that means that 95% of your points are going to fall within plus or minus 2 standard deviations, with 5% always outside of that. That's the statistical analysis, so 5 out of 100 or every 1 out of 20 points will be considered unacceptable. All right, so James Westgard is responsible for developing the Westgard rules. There are actually many more Westgard rules than the couple that we're going to talk about or asking you to learn. So the ones that you need to know for our purposes are the 1-2S rule. This is a warning rule. This is not a rejection rule. So if you only have one control, so say for example, it's your normal control, it's outside of 2 standard deviations, but still within 3 standard deviations, and your abnormal control falls within plus or minus 2, you could still run and accept that run, and you can still report patient results. But it's a warning rule, basically stating, keep an eye on this. Any of the other rules will be rejections. So a 1-3S rule is a rejection run. This is when one control is outside of 3 standard deviations, unless you have other points that combine with this. So again, it's 1 point outside of 3 standard deviations. That's considered a random error, but you do need to do a corrective action and determine what's going on before you report patients. And then we have a 2-2S rule. So that is where there is 2 consecutive points on the same side of the mean that exceed plus or minus 2 standard deviations. So you took the 1-2S rule today, but tomorrow when you run, you also have another point that's outside of 2 standard deviations on the same side. That now becomes a 2-2S rule. And it's a systematic error. Again, we're going to have to reject that run. And then we have a 4-1S. This is where we have 4 consecutive points on the same side of the mean. If you have multiple days, you should have a good scatter of your data around the points. Around the mean, so it exceeds plus or minus 1 standard deviation. But again, with the 4-1S, that exceeds plus 1 or minus 1 standard deviation on the same side of the mean again. That is again considered a systematic error. And then we have the 10x rule. This is where there are 10 consecutive points. They're on the same side of the mean. So it doesn't make any difference whether they're 1, 2, or 3 standard deviations, but they're all falling on the same side of the mean. And that there's 10 consecutive points. That is, again, considered a systemic error, and it would be a criterion for rejection. And then we have an R4S rule. This is the last Westgard rule that I'm going to ask you to be responsible for. This is a range or a difference between the highest and the lowest points within a run that exceeds 4 standard deviation. So we have a +2 is going to be the standard deviation, and then a -2 is another. So if you add those two together, they are 4 standard deviations apart. And that again is going to be a cause for rejection. The implementation of a multi-rule procedure. Again, we're going to calculate that we're going to run at least twice. So we have 20 data points we're going to calculate. The mean and the standard deviation on both controls. We're going to construct a chart with the mean plus or minus 1, 2, or 3 on your standard deviation limit. You're going to analyze and plot your data and on a chart for each analyte. So for all those analytes you run that chemistry profile, you have to have a Levy-Jennings QC chart for every level of control. So glucose is going to have a normal, abnormal, same with sodium, and so forth. So you'll accept the run if the points are within the plus or minus 2 standard deviation rules. Sometimes you need to back up and then look at the days prior. If there are no other rule is validated or violated, then you'll accept that run with the violation. If it has occurred, you can reject the run. You've got to do some corrective action, or you've got to document your corrective action, and then you're going to rerun again. If you reject a run for quality control, you cannot report patient results. A delta check is what we refer to as a comparison of patient results from current specimens with previous results. So for example, yesterday we had a patient that had a glucose of 400, and today the patient has a glucose of 50. That's possibly unexplainable difference, so we need to rerun it. It could be due to random error. It could be due to, who knows, they collected it incorrectly, it's the wrong patient, things like that happen. So you may need to pick up the phone and call the nurse or physician and find out what's going on, with the patient. Maybe they gave them some type of medication that's really going to drop their glucose, or, who knows. But if there's something that looks out of whack like that, always do your due diligence and double check before reporting those out. So in addition to our in-house quality control, we also do external quality control. So this is called proficiency testing. These have been mandated under legislation called the CLIA 88 unless the lab only performs waived testing. If you're in a hospital laboratory, you're probably doing testing that's considered moderate or high level complexity testing, and that requires you to do proficiency testing. So CAP and AAB are the largest providers of proficiency testing, and they will send you specimens on a quarterly basis. You'll run those exactly the same way you would run a patient, and you're going to report those results to them. And then from there, they're going to compare those results with your peers and make sure you're within the same, ranges to make sure that we're where we're supposed to be. Also, one of the newer things anyway in the lab is point of care testing. So this is analytical testing that's performed outside of the central lab. And this is also oftentimes performed by non-laboratory personnel. Your most common is going to be your whole blood analyzers for glucose. A point of care testing program is going to require planning, instrumentation, evaluation of the equipment, continual education for these patient care centers. There's a lot of turnover a lot of times in the staff that are doing the point of care testing. Again, typically they're not leveraged with personnel, and they need to understand that quality control has to be run and found acceptable before they're reporting patient results. A lot of times, like I mentioned, these are not lab personnel who are running these, so they don't really understand the importance of running quality control and ensuring that it is within range and how it can affect the patients if it is not. And then point of care continuing. So while patient point of care testing is usually a higher cost per test, the benefit is that it's a faster turnaround time, often shorter than if we were to do it in the lab. Um, the need for effective test request forms, we need clear instructions for patient prep and specimen handling. We need to make sure there's appropriate turnaround time for processing, testing, and result reporting, appropriate reference ranges, and intelligible result reports.